This week on the Backtable Podcast.
At the end of the day, the bottom line is all about what is the profit? Because no matter who it is, whether it's a junior partner, equity, hospital, whomever that wants to take over your practice, it's all going to be about profit. And that's the sad part, as we talked about earlier, which drives people to do things that maybe they wouldn't do if they were employed somewhere else, by institutions. But again, I think that's why we owe it to ourselves to be really stringent on how we deliver this care going forward. And we have to be very unified in doing it.
Hello, everyone, and welcome to the Backtable Podcast, your source for all things interventional and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, and on backtable.com. First, a brief message from our sponsor. This discussion is supported by Siemens Healthineers, venturing into outpatient care with clinical, business, and financial decisions to consider. It may feel like you're exploring new territory, and the stakes are high for you, your patients, and your practice. Now imagine you have an experienced partner to help you create a successful, sustainable practice. Feels like a relief, doesn't it? Siemens Healthineers is here to empower you in every care setting, every step of the way. Visit siemens-healthineers.us to discover how healthcare providers leverage the specific expertise, products, and services from Siemens Healthineers to meet their unique outpatient care goals. Now, back to the episode. Today, we've got a very special episode with Dr. Mahmood Razavi and Dr. Mark Garcia. We're going to be discussing the pros and cons of owning and operating in an OBL. As in the past, on these OBL topics, I've actually collected some questions from prior guests and OBL operators for today's guests to give their insight. In case you haven't caught prior episodes that are extremely relevant and also very useful, Bill Julian's episode 329 on the history of OBLs was fantastic. He also did episode 375, where he talked about getting independent privileges for IRs, as well as we had an episode with Brett Weichman on episode 368, talking about insurance denials for CLI, and then episode 202 on staffing the OBL with Dr. Krishna Manava. Just some highlights for people if you want to learn more about the OBL situation. Gentlemen, thank you so much for joining.
Thanks for having us.
Thank you for having us, Aaron. Really appreciate it.
Yeah, so let's start with introductions, where you're at and what your practice looks like. I'm going to start East Coast to West. Mark, we'll start with you.
All right. I'm Mark Garcia. I'm an interventional radiologist, and I was in a private practice, large radiology group for almost 18 years. The hospital that we were working at, Hostley, took us over, and I was employed and continued to run the interventional radiology section and the Heart and Vascular Center, peripheral labs for 3 years, and then decided to go out on my own. And I've been in an OBL now since 2017. I opened the private practice, solo practice, and was basically hospital centered at the beginning until the OBL was built, which didn't open until February of 2019. And so our OBL has been operating since 2019, early 2019.
Fantastic. Thank you. Mahmood.
Yeah, at the beginning of my career, I was an academician studying academia. About 17 years ago or so, I saw the light and left and came down to Southern California. It's a multi-specialty group, a mix of vascular surgeon and interventional radiologists. And I've been here in Southern California, Orange County since then. In 2019 or so, we started our own OBL. So for the sake of disclosure, purposes of disclosure, although I'm going to argue somewhat against OBLs, mostly on the impact on the societal health and on patients rather than on the physician. We do have our own OBL that we operate. And so I've been here since.
One thing I forgot to mention in the intro was Dr. Mahmood's episode with Brian Hartley back on episode 140, where he talked about starting a med tech company, which is also fantastic. So please, to the audience, go back and listen to that as well. Thanks for the introduction, gentlemen. I wanted to start with the pros. So I was just at Western Angio in October in Palm Springs, and there was a fair amount of presentations, discussions around practicing in an OBL. It was funny because some of the academic folks were walking out one day and they're like, if I hear another talk about an OBL, I'm going to run out of here screaming. And it was, but for those in private practice, I thought it was really practical and useful. And so I wanted to start with you, Mark. In your opinion, before we get to the challenges, what have you found since 2019 have been the big advantages of working in the OBL setting? Does it live up to the hype?
Great question. I will say that I think there are a number of advantages, and then we'll talk about the challenges that we all face today. But some of the major advantages, I would say, number one is the autonomy. You're in charge. You get to run the ship, and you can steer it as you deemed helpful and most, advantageous. Now, you have to obviously have some insight as to where things are going with medicine and patient care, but hopefully most of us are all focused on patient care. But that autonomy leads you to being able to make quick changes. There's no committees, red tape to go through, ask for certain things in the hospital. If you want a new device, if you want to change your protocols, if you want to do certain things that you think, improve patient outcomes and patient care, then you can make those changes on the drop of a dime. I think the biggest thing is patient satisfaction. I can tell you that in our practice, I often will give patients the option if they want to go to the hospital, because we're unique. My OBL is actually in the medical office building adjacent to the hospital. They have no ownership in it. It's just, that's the way it was set up. And so I have that option saying, do you want to go to the hospital? Do you want to stay in the OBL? 95 to 98% never want to go to the hospital. They'll do anything they can to stay away from it. So their satisfaction is great. Our satisfaction scores that we give our patients come back tremendous. I think that we are able to deliver quick and very high quality care to patients. As we'll all talk about, the expense of healthcare today, which is quite significant, we make, I think, a great impact on cutting costs to the healthcare system because of the less expensive procedures that we do overall, and the reimbursements are less. And lastly, the advantage would be financially, it can be very rewarding if it's done right and you have a good OBL. And that's probably the biggest challenge, is making the financially worthwhile. So
those are all great points, Mark. I can't argue with any of those except the cost issue. The issue of independence is important. Autonomy for the physician, very important, no doubt about it. And doing away with the hospital BS and the administrators and all the committees and things, no doubt about it. Clearly improved and easy access for the patients to the extent that we can keep the patients happy. And as you well know now, more and more of them have sort of heard about all the quote unquote issues in OBLs. And sort of some of them, at least in our practice, and that has to do probably unique somewhat to our county, because there are several OBLs and not all of them operate at a level that is necessarily good for patients. Having said that, no question that there's improved access and it's easy and the patients like it. I don't know. I can't argue with any of them. The two things that I would sort of want to point out. One is you referred to the issue of cost, the healthcare cost being high. The cost savings does not necessarily, in this case, equate to elimination of waste. In fact, we'll talk about it when we get to the cons issues. And one of my major concerns about the OBL operations is the fact that there is increased utilization that is not completely captured in that cost equation. But we have to be careful that when we talk about cost, that we're not talking about, it doesn't mean that it's eliminating waste. The other concern is that, this issue, when we talk to a lot of physicians and they all say, well, yeah, I have some freedom and decision making, all of that, which you actually alluded to. My question is, the restrictions that we face in OBLs are self-imposed rather than administrators imposing. And is that any better? When we choose what inventory to carry, what to use, what imaging equipment to have, there is a component of cost consideration in that. So we impose the restrictions ourselves. Therefore, we feel less violated by administrators because we're doing the violation ourselves. So those are the concerns that I have, that it's not as free as we think. It's just the lack of freedom is imposed by ourselves. And, Aaron brought up an issue that a lot of academicians are saying, well, if I hear another OBL, I can't tell you how many phone calls I get a month from various academicians wanting to start their own or wanting to join. And they're wrestling with keeping their academic appointments and privileges and enjoying all the issues that Mark talked about of an OBL. The statistics, I'm sure, in the previous episodes that your guests have referred to, that there is a double-digit expansion, OBLs in interventional radiology. The sector altogether, the compounded annual growth rate, financial, not numbers, financials, are around 7.5% or so per year, estimated growth through 2030. IRs is over 10%. And a lot of people are calling to find out about it. I'd love to see what challenges Mark faced and I can share ours. It's not as easy as they think.
I would agree. And just to supplement some of that, I will tell you, so yes, the numbers all speak for it. SIR, as you probably know, has had a movement towards now having some focus on OBLs and private practice, which in the past we really hadn't done. So thankfully that's happening. I will tell you, I just wrote a chapter for TVIR, which I'm not sure when it's going to be coming out in the future, but it's mostly OBL. Brett Wakeman was the guest editor. And my chapter was a lot of what we're going to be talking about today. I will tell you, I've never worked harder in my life. I worked hard when I was at the hospital, but I've never worked harder in my life. So this is not for faint of heart, and we'll get into a lot of those issues. But Mahmood, you're right. I mean, we do have a lot of our own self-restrictions that are put on things, but what's going to really drive, I think, this in the future for the advantages is coming together. I think one of the biggest problems, and this is true in medicine in general, one of the biggest problems we have is that we are very poorly focused on helping each other in the sense of a big mass. We are all too busy to get involved with government and some of the people who are trying to focus. We have this thing called Virtual Hill that we were speaking to our Congress and senators back in September, and we sent out notices to everybody. I'm a big part of that with USPA and the CVC. And it was so poorly attended that it's like, how do you talk to the government when they get, 20, 30, 40 people nationally that are involved with this who have a concern about the reimbursements? We have to come together as a mass and support what we're doing. And this is even in the hospitals. This is everybody, because we're just getting hammered. And unless we speak as one unified voice, I just don't think we're going to get anywhere, because the government's focused on budget neutrality and they're focused on so many other things going on in the world that, medicine to them is just something they have to keep ratcheting down on and cutting costs. That's how they see it.
Yeah. I mean, the biggest challenge, like to go back to the academics reaching out to Mahmood, the biggest challenge to me, because I was in the OBL space for just 2 to 3 years, was the learning curve to the business side, right? You get out and you're really excited to do the cases and have the autonomy and not have to work in the hospital with all the headaches and the admin and so forth. But navigating insurance and staying on top of what pays what, that's another full-time job. I mean, it's like 2 full-time jobs really. And to go with what you were saying, Mark, you've never worked harder. That's, I think, what people don't appreciate. Just kind of a con, I think, that I experienced.
On that issue, and Mark obviously has alluded to some, and I'd love to hear the rest. My key advice to people that want to get into OBL is that it's independent of the specialty, but particularly applies to the interventional radiology, is you have to know where your patients are coming from. Wishful thinking is not a replacement for a good business plan. We had, recently 2 very nationally known, one interventional radiologist, one cardiologist, who are in, high administrative positions in academia, had talked to me about, this is their plans, not necessarily, asking advice, but they said, this is our plan. We want to do this. And the first question I asked them is, where are your patients going to come from? Are your current patients referred to your institution or to you? Do you have a network of referring guys, or are you sort of saying that, well, I'll go out there and I advertise? It's important to know that. That's the first question you have to ask. And then know what your upfront costs and recurring costs are. When can you expect to be profitable? It's just simple, very simple business plan. And if there's some build-out costs, the TIs, there's a cost of a space, the staffing, equipment, who's going to manage it all? Who's going to bill? Do you have contracted the payers? Is CMS going to pay you when you're out there? These are the things that they need to work out ahead of time. That's even before you get into what is my fixed cost and what are my operational costs. Fixed costs would be part of the operation cost. What are the disposable costs? What is the cost of my imaging? All of these. It's not as simple that, hey, look, OBLs make more money. I'm going to be out there. I have all the advantages Mark talked about. Let's just do it tomorrow.
Yeah, those are great points. And Mahmood, I'm chuckling only because when you said your first question, everybody is where your patient's going to come from. I exactly say the same thing. And I agree with you because, and as you said, IRs are over history have been weak in sort of having that plan of how to get direct patient referrals. I think we're much better than we used to be a decade ago. You learn some of the ins and outs as we do it, but you're right. I mean, it's important to market yourself, to have websites, to go speak to physicians, to talk about what your service line is, what you're offering, and that is the first question. It's a lot of groundwork. You can't just assume you're going to get patients because I think people do get referred to the hospital generally, not to you as specifically. I enjoyed a practice where I was at in the institution where I did have a lot of people who came from out of town for some of the venous disease that we were treating. But you really have to do a lot of legwork. You've got to get on the ground and get into your referring physicians' offices. You got to talk about your service lines, the benefits of them referring to you. There's just so much work that has to be done. And that's part of why I said I've never worked harder. And you're right. You have to know everything. You have to wear many hats, not just a clinician, but the business hat. Sometimes you have to be the human resource director, know where all the dollars are. What have you been denied? Why have you been denied? The insurance plays an incredible game with us now today in this world. They've learned deny. And they think that because you're in a private practice, somewhere around 180 days that you'll just drop trying to get your money back. And that's been actually quoted by one of the healthcare presidents to a large GI group that they were telling me about. So it's just constant hitting the pavement and really understanding all about your practice and all about your finances and all the things we've talked about so far.
So, Mark, you guys have a very nice center. What is your fixed cost per month? Do you know?
Yeah, fixed cost per month generally runs about, I'm going to say the rent plus our capital equipment and so on, probably in the realm of about $30,000 to $40,000.
And does that include the staff?
That does not include staff. So, that's additional. I can tell you that generally speaking and this is without my salary, which, since the last couple of years, because I'm the owner, I've taken a decrease in salary, significant cut to make ends meet post-COVID. But, we're growing, we're back up. But in general, we've got to make anywhere from $175,000 to $200,000 a month to stay on top of all of our costs. Now, that's not fixed costs only. That's all of the cost of goods and equipment and so on, the disposable equipment and so on.
And then your salary, on top of it, obviously.
Yeah.
And so this is just so people can have an idea of once they open the door, this doesn't even include the cost of construction and the tenant improvements and the change in the space and all of that. Remember that in those costs, you have to consider the fact that you need more space and so therefore more rent. That's typical of, I was expecting you to say, because you guys have a pretty nice space, is that it's about $200,000 a month, which is, 170, 180 is close. So you have to make that much money before you can even pay yourself.
That's right.
So people have to consider those and know exactly what type of procedures, what the payments for those procedures are, and how many of those do they have to do to profit the amount. And that doesn't even include the cost of disposables that we have to use.
Yeah.
The equipment that you use, if you're doing atherectomy or embolization procedures, there is a cost to those procedures. It's important. For example, in our practice, we draw our patients from our vascular lab and from our office, right? They come to our office. We can tell them, I'm going to do your procedure here or at the hospital. Most of the critical limb ischemia patients, we do them at the hospital. Claudicants, we do them at the office. Blood clot anywhere, we do them at the hospital, so on and so forth. Some of it has to do with the reimbursement. For example, for DVT, we probably haven't have issues collecting if you do it in an OBL. Have you had any issues, Mark, with DVTs?
Yeah, for the extensive chronic recanalizations, I definitely do in the hospital because most of those take a lot of not only time, but there's a lot of cost of goods, disposables, multiple stents for the IVC and iliacs, which would bankrupt you, you know. So a lot of those. Now, if it's just simple chronic iliac vein occlusion, I'll do those in the OBL. If it's a partially recanalized FemPop, for example, in a chronic DVT patient who's got C3 or greater disease, I'll do those in the OBL because I think prolonged balloon angioplasty and some of the interventions we do there can be okay, profitable. You're not making a ton, but again, it's also about patient satisfaction. But if I have any concern whatsoever, if a patient has, for example, comorbidities that make it very cautious, we've had a number of patients, for example, also that we've done some CLI work on, but as soon as you give them a little Versed and fentanyl, they start moving all around. They're asleep, but they have involuntary movements. And so it doesn't bode well trying to recanalize some tibial vessels, even the SFA or POP. If we find out, those patients will obviously go to the hospital too. So a lot of it's based on comorbidities, yes, how involved the case will go and how much we think cost of goods will need to be used. And then lastly, sedation and whether or not we need anesthesia versus moderate sedation. In Delaware, we have a certificate of need. You can't become an ASC unless you get through a certificate of need, which is incredibly difficult. I'm hoping in the future that the governor will change that and allow us to practice because I can't give anything but moderate sedation. We're not allowed to have any anesthesia as an OBL in our state. So one of just the nuances, many states don't have that, thankfully. We're one of the last few that I'm aware of, but there are all these challenges we have to all address.
It's the same in California, but this goes back into the point that you have to have a good business plan going into this for those who are thinking about it. They need to know all of these. What type of procedures? What does the reimbursement look like? What is their margin for each type of procedure? And how many do they have to do to meet the costs that we just talked about? And I'll bring up one more issue, and that is that problem that we had initially. That when we opened up our OBL and started doing procedures there, we had to change billing company. And the billing company that we brought in, we had a lot of challenges with them. They didn't know how to bill for in-hospital procedures. And since we are a mixed group, that became an issue. We lost a lot of money there until we found the right billers. Little things like that can make a difference whether you're profitable or not.
Yeah, two things I'll comment on that is number one, when you talk about getting yourself prepared, the most important thing in the beginning is developing or creating your pro forma. The banks are going to want it. Investors are going to want it. You should see it because that pro forma is going to give you an honest look at the procedures you're doing, the volume you'll do per week, per month, per year, how long it will take you to be profitable. And it'll also give you an idea of looking at what procedures and start to look at the reimbursements for each thing. For example, when we did our pro forma, I had included in that a lot of biliary and tube changes and nephrostomies and so on. But when you start to look at it, they're just nothing but essentially a money loss for us in the OBL.
Yeah, no.
And so we have not done any of those because you learn very quickly.
Yeah.
You can't do them. You won't be able to stay afloat. So that pro forma is really important to understand reimbursements and the volumes and where your patients are coming from, as we talked about before. It is very challenging.
So what do you think of alternative models? As we talked about, there are academicians who don't want to necessarily lose their academic appointments, or they want to stay in the hospital and maintain the good relationships. How about joint ventures of the hospitals? Or there are now large service providers, right, backed up by private equity or other medical groups. You know, there was at one time a group of GI physicians who wanted to come into our facility, which, you know, provides additional revenue for you for the unused portion of the time. What are your thoughts about joint ventures, Mark?
Yeah, I think the joint venture is a model that I would seriously consider. You know, I've had the benefit of having a lot of great relationships with multidisciplinary practitioners in our state from before. I think that there's a definite benefit from referral source from patient access, that if you are in a multidisciplinary group, and I believe you are, Mahmood, so you can talk more about it than I can, but I think there's definite benefits. The models that are out there, they're becoming so much more vast. I mean, private equity is definitely getting into all sorts of medicine, right? I mean, they are going to be the big gorilla, I think, if they're not already in healthcare delivery in the future. That may not be a bad thing. They're very, very keen on keeping costs down. And, again, then you have a lot of business people involved in medical care, which can be challenging. We see that in hospitals who have administrators to the top that are just all based on finance and not really delivery of quality of care, I should say. But I think some of these models ought to be investigated. I think if you're going to do your due diligence, which all of us should, I recommend people take a good year to really look at the OBL scenario before they jump in. And they should do those steps we talked about, some of the pro forma evaluation. How are you going to finance? Are you going to try to involve private equity, or are you going to do a multidisciplinary group? If I had to do it over again, a couple of things I would do differently. I probably would consider multidisciplinary approach to things with vascular surgery or interventional cardiology. I would probably consider doing a partnership in the business side of things as well. I mean, I did everything on my own. My wife and I basically went and got loans and built out everything. Consider the hospital as a partner. We did do that actually in the beginning, and the plan was to go forward with that. And then COVID changed all of that from the hospital standpoint. I think all hospitals got, hammered as well as we did with our revenue. So anyway, there are a lot of options, Mahmood, and I think you should talk about your multidisciplinary group that you have, unless things have changed since I've last talked to you about it.
No, we're still in the same group. I think we may be one of the very few that, as you recall, back in the early 2000s, the vascular surgeons wanted interventional radiologists and vice versa. And there was a mutually beneficial relationship, and most of those fell apart. Ours has lasted. I joined the group after they had formed. So I had nothing to do with formation of the multi-specialty group. And it has lasted. And as I mentioned, we draw our patients from our offices, vascular lab mostly. And then one of our younger interventionalist radiologists has done a pretty good job on developing things outside of the vasculature for our OBL. So here's my concerns. And this is where you and I may differ or may agree, Mark. Up until now, we've agreed on most things. And that is, what is the impact of these OBLs on the healthcare in general and on patients, society? The costs, when we say cost saving, it is from whose perspective are we talking about? Because those can be very different. I have a serious concern that when the decision on procedures become based on financials rather than data, then we are walking a very slippery slope. We've all seen impacts of those in our communities where there are a lot of OBLs, like, Orange County, there are a few. I can give you a lot of anecdotal experiences, but there's some national data on these, that delivery may suffer. And I can start with one example, and it doesn't necessarily have to do with the skill of the physicians. Because, there's, for example, an outpatient lab in our community that we call it the good source of amputation for us. And a lot of the work they do has to do with the strategic decision, but those physicians could make the same mistakes in the hospital, right? So I can't say it's the fault of the OBL. But there are decisions that are made. Just a couple of weeks ago, a 50-some-year-old, very healthy lady comes to our practice for a quote-unquote second opinion. And the only complaint she had prior to this was she had some sort of varicose veins, which was really not varicose. It was just mostly telangiectasias and things on her lower leg and one of the legs. And she was told that she needs the saphenous vein ablation. And so she had the saphenous vein ablation. And then after that, they told her, oh, you have ovarian vein reflux and you need that embolized. By the way, no symptoms. So she had undergone ovarian vein embolization. And then, you also have a May-Thurner, albeit the varicose veins were on the right leg. And so she got a stent there, and she had developed in the interval some pain from the ablation procedure that my guess is probably, below the knee, they injured the nerve. And they said, you need an arteriogram. So at this point, she said, maybe I need a second opinion. And we've seen a lot of these. And this is an anecdotal example. And we see a lot of that in our practice from particularly some of the outpatient labs in our community. But that is duplicated across the nation because there's not good data. There was, one of them was published in JVS in 2021 by Togo and his colleagues, that when the doctors switch to OBLs, they perform more interventions as compared to control, and they perform more procedures per patient as compared to control. The odds ratio of repeat intervention increases, both at 30 days and 1 year with no significant improvement in any clinical outcome, like the arterial side, for example. If you use major adverse limb event as your endpoint, no improvement in that, yet there's an increase in intervention rate. It's been well documented that high OBL use doctors had a highest 30-day and 1 year reintervention rate, 15% at 30-day, 40% at a year. And we all see anecdotal issues like I referred to, and at the national level. So that's something that we cannot hide from. Bad apples, of which there are a lot, will probably spell significant issues for OBLs and the reimbursements to the OBLs down the road from these types of statistics.
Yeah, no, listen, unfortunately, as we know, there are bad players, but there are bad players because we're human beings, right? There are bad players in politics, in religion, you name it. There just are. And the question is, I think there's twofold. Number one is, how do you weed out those bad players and hold them accountable? And medicine's been very poor on that because we don't like ratting on our peers. And so that's been a challenge for decades and decades. As an OBL society or subspecialty, I think that it's going to be imperative of a couple things. Number one is, I think OBLs all should be accredited. I think accreditation is the first step to having some respect, not only by your peers, by the state, by patients. I think they feel better when they know. And unfortunately, a lot of patients don't even understand accreditation, right? So they wouldn't know the difference. But I think as it becomes more public, it would be better. Are you an accredited facility? Because we have to report all of our adverse events to Quad ASF, who we are accredited by. It costs money. A lot of people argue, I don't want to spend that money, but that's money that's well spent for the future of medicine and for the OBLs, for yourself. I just believe tremendously on that. The second part of it that I think is important is, where do we go with our societies? I think it's very important. And you and I know a friend of ours who was very adversely affected by a report in the New York Times. And it really came badly across what OBLs do. And then people started jumping on the bandwagon, saying all the horrible things that occur. Well, we've all read papers that are supposedly well-written, well-respected people that are in good journals that are very one-sided. And I think that we have to look at the information and the data. And here's a perfect example. If you were to look at our OBL, I practice in an area that has a significant underserved, I would say medically poorly educated. If you looked at the number of procedures we do without having, for example, exercise program as a first resort, I will tell you more than half of the patients I see have gangrene. They're Rutherford 5s. And so you can't just look at something and say, oh, this doctor just does so much adverse stuff. I mean, it's horrible. And I tell the patients all the time, look, I'm a plumber. I can fix the pipe, but I can't fix your hypertension, your diabetes, your high cholesterol. You need to take meds. You need to start exercising. You need to change your lifestyle, because otherwise you're going to be back in here. And whether you're back in here every 3 months, 6 months, year, 2 years, I have no idea. But we need to work together trying to control these things. Those are guidelines that I think societies need to come up with the OBL. And that then brings up the question, whose responsibility is it for us to oversee what we do? And I think it probably is going to be a concerted effort from SIR, the Societies of Vascular Surgery, for interventional cardiology to come together with OEIS. Maybe we form a separate accrediting body or some sort of guideline information that we have to follow. I hate the idea of being forced to do things, but I think at some point we all need to be able to stand up, whether it's in a court of law or on the podium or wherever, that we can say, I did the right thing. I followed these guidelines, and you can bash me for whatever you think I've done right or wrong, but I follow these guidelines. I'm accredited and I do the things that are clinically relevant. And until we get to that point, Mahmood, I think you're right. I think people are there probably is some over or abuse of some things that go on, but I'll also tell you, I don't think that doesn't occur in the institutions. I think some of these ivory towers, I can tell you, having been in one for 20 years, people do stuff that they shouldn't be doing, and that's a whole nother issue, is quality of care. But I don't think it's just unique to the OBLs that people abuse things and do more than they should at times.
I agree, but it's more so in OBLs. Look, we know that the New York Times article was basically a character assassination. Okay, but the point being that some of the issues they bring up, not applicable to that particular practice that they were after, but in general are correct. And that is that the practice of vascular interventions, peripheral vascular interventions in OBL is not evidence-based. It is cost-driven. Cost to the provider becomes a dominant consideration rather than the evidence-based practice. Why is it that there's such a disproportionate use of atherectomy in OBLs versus hospitals, and reverse is true in drug-eluting technologies, where there is level 1 evidence for use of drug-eluting technologies in patients with peripheral arterial disease, and yet it is so poorly used in the OBL space? These are the issues that you're right. We need accreditation for, but now we're talking about regulation. We're talking about increased costs. We're talking about loss of freedom. All the issues that you referred to at the beginning that are advantages of OBLs, we have to give them away. One of the other concerns and the reasons the costs in the OBLs are low, because there's a lower safety standards in OBLs as compared to ASCs or hospitals, right? Lower requirement for personnel, construction, you name it. And if we submitted all of that to regulation, which I do think is going to happen, and we should, because as these types of abuses get more prevalent and more advertised, and there are all sorts of not only reporters who could make a career based on these things, but there are also a lot of legislatures, as looking at it rather than looking at reimbursement and how do they change the reimbursement to correct some of these. All of these then, one by one, will start doing away the advantages of OBLs. There are currently about 600, more than 600 or so OBLs reported in the U.S. You guys may know the statistics latest better than I. And that includes OBLs that are focused on the spaces that we're talking about, vascular, basically like interventional cardiology, vascular surgery, and interventional radiology. I'm not talking about the GI labs and ophthalmology and all of those. Those are thousands of those. It's about 600 or so, almost all of them moms and pops shops. There's going to be a consolidation in this space because not all of them are going to survive a single regulation that comes down the line. One of the points you made to me, Mark, was that the reimbursement has gone down by 15% or so in the past 3 years. What was the statistics you quoted?
Yeah, if you look overall, the OBLs, I mean, it depends on exactly what you're talking about. But in general, in 2023, we saw overall a 9%, but in some cases up to 23% reimbursements for certain procedures. This year, we're going to see probably another 5%. ASCs have gone up about 5% over the last couple of years. When you look at reimbursements to subspecialties, you look at interventional cardiology, you look at vascular surgery, and you look at interventional radiology, the overall reimbursements for physician fee schedules since 2006 are in the realm of 25 to 28%, I think, for the IC. Vascular surgery is almost 31%, and IR is like 38%. So this is going over since 2006.
And that's a note to the policymakers. That's what's driving the OBLs. And so the question is, whose fault is it that all the abuses occur? Part of it, human nature, as you talked about, but more common in OBLs. And, we've been talking for a while now. So before we get done, we need to talk about whose fault is. And I think, and I put the primary responsibility squarely on the shoulder of CMS with this perverse reimbursement policies that in the real world have no basis on being the way they are. And then, of course, organizations with profit motives who do move into this space or have moved into this space, that they're the ones I think will take away more physician freedom than any hospital I know. And I'm talking about private equities, VCs, and things of that sort. And of course, doctors, us physicians, will react to the market conditions. And so I'm not, I fault people for doing what they're doing and their abuse of the system. But when profit motives take over, you can expect that.
Yeah.
So what is needed, Mark? What is needed? So you talked about accreditation. How about regulatory oversight? I mean, that is an accreditation. How do we expose and eliminate the bad apples, of which there are about 30 or 40% of the OBLs in one guesstimate? And how do we establish a culture of quality in OBLs? Like some of the practices that we all are aware of have that and practice good medicine. How do we extend that? And then what we don't want to happen, which is happening, is remember, we're in the age of big data and, outcomes can be captured. And I think we should probably, as part of the accreditation, force everybody to participate in one of the national registries. And that should be a prerequisite for reimbursement. So now we're talking about regulation again.
Yeah. And most of that I agree with. One thing, we have to be very careful is how we develop these sort of things, because the last thing we want is, and if we don't do it ourselves, it's going to be done, I think, in the future. I don't know when that's going to happen, but I can see government coming in and establishing the regulations that we're going to have to follow. So we ought to do it ourselves before it happens. I do think that we have a responsibility. I wish I could say that all people that are taking care of patients have nothing but their best interest in hand. But we know, as you said, that there are bad apples out there. And I do think we have to figure out how to best address these. I do think it's an onus on all of our individual societies, and that I think we should largely rely on OAIS it's probably one of the better potential oversight bodies, that they're focused specifically on outpatient delivery of medicine. So maybe they ought to be involved with trying to not only establish guidelines, but create that vehicle, which we all have to put our information on, that registry. They do have a registry that is actually quite unique and quite inclusive. We've done it, and it's a great registry, I think, that would look at all of these outcomes. We have to do something, Mahmood. I think we're all faced with a lot of uphill challenges. And unless we take the driver's seat ourselves, and we're going to be regulated by someone outside who doesn't know what the hell they're doing, which is what happens all the time in hospitals, right? That you get told what you can and can't do by people who are in some committee that don't even know what interventional radiology is, for example. But it's time for us to all get serious about this and come together and decide how we want our futures to be driven.
Hallelujah to that.
Mahmood and Mark, you mentioned the rising rates of OBLs and the number of OBLs that exist. Is there any data around the percentage of OBLs that actually close down over a certain period of time? Or do we have anything that out there in the literature or anything in healthcare news?
I'm not aware of that, but I do know many of those that have come up, and that has to do with people, again, thinking, I get the patients, they go set up stuff, and then they close it a year or two later. The numbers that people are throwing around, and I want to caution you, in terms of growth of this space and that high single-digit CAGR that we talked about, it refers to the number of dollars. It's a financial sector is increasing. That means the number of patients done, all of that. It does not necessarily refer to the entities. As I mentioned, the guesstimates are there are more than 600 OBLs in the United States. That may consolidate. The number of OBLs may not go down. They may increase, but the number of people who are operating them, so they come under a bigger umbrella and they become big conglomerates themselves, because there is no other way for everybody to survive. Moms and pops shops are not going to survive. The realities of a market-driven economy will take over. And not all of these are going to survive. They're going to have to go and become part of a bigger conglomerate.
Yeah. So Mary Cosentino wanted to know, what do you see as an exit strategy for single operator OBLs out there? And we kind of already talked about private equity, but then just this consolidation, it sounds like we just lose that autonomy like we did in the hospital.
Yeah, the way I look at it is, it goes back to our episode 134, 143, whatever you talked about.
Yeah.
That how do we start the medtech business? Is I look at these as a startup and the same rules apply. And so you could go commercial in a startup company, which means you continue the business in an OBL and you're making good money and you move on and you grow. At which time you become a target of acquisition. So be it. I consider all the next door hospitals and the private equity and venture capital guys who are getting into services as potential future of exits. It's just that they have a very stringent way of which practices they would take over and where they are. So it's a very strategic approach on their part, which you would expect. And you just have to make sure that your practice fits that. From day one, the way you set it up, you have to know what their requirements are, what their checklist is. And you have to make sure you go down the road and just check all those boxes. And once you do, become a target. At that point, sure, sell. And then you lose your independence and you submit to them. But that's the way I look at it. That's one exit. The other one is you just have to make sure that the source of the patients and the type of procedures you do are profitable. Otherwise, you just won't survive.
Yeah, I think he's right. I think, the one golden nugget out there in front of us all is to be bought out with great multiple of your EBITDA for private equity come in. I mean, that is one strategy.
You want to say what EBITDA is, Mark? You want to describe what EBITDA is?
Basically, it's your profit. I mean, it's defined, but it's your profit and loss. What is your true profit that you've made at the end of the year, your net? And then there's a multiple of that. And so you can do that. And that may be, what I think we all kind of see as one significant way of exiting. But you're right. You give up a lot of autonomy and you're an employee now and so on, depending on how it's structured. The other is to just have junior partners come in and slowly take over and have you phase out as a part-timer and hopefully collect still a good salary and let them take over and kind of continue your legacy of that practice until you're ready to retire and have a buyout from them. I think that's a little bit more difficult in this era, but it's still a possibility. Unfortunately, the exit strategy is probably a lot harder than the entrance strategy getting in this day and age. But I think Mahmood's right. You really have to think long-term when you start into this whole practice. You have to think about that future. What's going to happen in 5 years, 10 years, 20 years? What am I looking to do to exit? And how am I going to make that happen? Because at the end of the day, the bottom line is all about what is the profit? Because no matter who it is, whether it's a junior partner, equity, hospital, whomever that wants to take over your practice, it's all going to be about profit. And that's the sad part, as we talked about earlier, which drives people to do things that maybe they wouldn't do if they were employed somewhere else, by institutions. But again, I think that's why we owe it to ourselves to be really stringent on how we deliver this care going forward. And we have to be very unified in doing it.
Just curious, what is that multiple? Have you guys heard of what multiples are these days or historically?
Yeah, typically, I think most people look for, depending on the profitability, between 2 to 4 times. I know there have been practices out there that have gotten 8 to 10 times their EBITDA or their net profit. So it can be very lucrative for people who've really developed that incredible practice. And things that you learn are that, if you're a single provider, you could be generating 10 million a year in profit, let's say, or 5 million. It doesn't matter what the number is. But if you're a single provider, what people from the outside, like the private equity, see is that you're the single provider. You leave, there's nothing in that practice. So there's a lot more value in a practice that has multiple providers because they can take over and continue that profit. And so it really, the design and how you are profitable depends on a lot of factors, including what I just said, like how many providers you have, what is your referral source, how strong is it, the marketing, all of these things come into play for your value.
Yeah, absolutely. The key consideration is the patient flow. Is the patient flow and the types of procedures are sustainable and your numbers look good, then you could potentially become the target. And then the issue that Mark brought up in terms of single provider versus a larger, it's a valid one. But key issue is which market we're in, geographic market. Okay, some geographic markets are more attractive to investors than others. And is your business sustainable? Are the sources of patients sustainable? Are you a primary referral? Are you secondary? All of these things matter. And at the end of the day, I don't know what the multiples should be or are. We've not been in it long enough, but it's a 3x return is fantastic for this type of work.
And one thing that should not be lost in this conversation is if you set up a multidisciplinary or multiple provider group, it's very important that you all have you're all aligned in your goals and the method of practice and so on. Because at the end of the day, if you are going to try to sell, what happens is everybody has to agree to it. So if there are people who don't have the same future goals in line that you do, it can become very ugly. And so you just have to make sure that you partner with people who are of the same mindset and same goals in delivering your healthcare.
Well, gentlemen, it flew by because you guys, it was a great conversation, great discussion. Any last parting words before we wrap up here? Mark, I'll start with you.
No, I think, if you're interested in starting your OBL, all I would say is that take the time, due diligence. As I said, steps that are very important are figuring out your pro forma, knowing your marketplace, look at the different options that are out there, consider partnering with people. I think it's important. Like I said, doing it on my own, I would not recommend. Now I've become chief medical officer for American Vascular Associates. These sort of partners with physicians in multiple aspects. They can do billing and, your management services. That it's not something that's very easy for most physicians to get involved with. So I do think that however you do it, you've got to have people involved that know what they're doing to make it easier for you. And then join with people that are of like mind, have the same desires of delivering the care that you want to have, be quality driven.
Absolutely. The culture has to be one of quality care, high standard care from day one, and no wishful thinking. I can't tell you how many people that I talk to that when you ask detailed question, they say, well, that's going to take care of itself. It won't. You have to plan it. And also remember, there are a lot of shysters out there that would get a lot of money from you to give you advice and you get nothing at the end of it. So be careful. Consultants are great. Asking around is great. You have to have them, but have the right ones.
Yeah. And my last comment would only be when the time comes, please step up. I mean, it's very, very important that we all join in making strength when our coalitions, the USPA, CVC, all of us that we try to help benefit the OBLs. It's important for us to join and to have a strong voice.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_Backtable on Instagram, Twitter, or LinkedIn. Backtable is produced and hosted by myself, Aaron Fritts, and co-hosts
Chris Beck, Sabine Don,
Michael Barraza,
and Ali Behetti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang,
Manisha Naganathanahali,
and Manveer Singh Sabri.
Administrative support provided by Jamila Kinnebrew.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening.